Hi, my name is Gunnar Thomasson. I'm a rheumatologist based in Reykjavik, Iceland, and this presentation is to provide the overview of our project of creating composited response criteria for ANCA-Associated vasculitis. We believe there is a strong case for composite measures in AAV. The disease impact of AAV is not the one thing, but a combination of multiple elements that can be assessed by physician-based instruments, patient-reported outcomes, and biomarkers. This slide shows the major discoveries about the AAV in the last 40 years. In 1995, the Birmingham Vasculitis Activity Score, or BVAS, was introduced. It is a continuous measure of disease activity, but in reality a checklist of various vasculitic disease manifestations where higher number of manifestations present results in a higher score. In reality, BVAS is almost always reduced to a dichotomous outcome for the purpose of endpoint in clinical trials. BVAS has introduced harmony and standards for conductance of clinical trials in ANCA vasculitis, and these trials have taught us a lot about AAV, introduced rituximab as a new agent, and optimized the use of cyclophosphamide, resulting in much lower toxicity than previously. As a result, the clinical approach to AAV now is considerably different than it was when BVAS was first introduced. Outcome measure development is an iterative process where good outcome measures facilitate conductance of RCTs that advance treatment to the point that the need for other kinds of outcome measures becomes evident. We believe that we have reached that point with respect to AAV. Lastly, to select new treatments that offer benefit regarding disease aspects that patients think are important, primary endpoint definitions should incorporate the patient perspective to some extent. As part of this project, we have conducted a systematic literature review on the outcome measures that are used in AAV RCTs. This project was led by Dr. Sara Monti. The main findings are that the trials differ considerably in their definitions for remission and relapse. Intermediate disease states are poorly defined. Patient-reported outcomes, damage measure, and global assessments are often not included. Also, a part of this project we have conducted in collaboration with OMERACT a Delphi exercise among both patients and clinicians to identify the most important items to assess when quantifying treatment response. This project is led by Dr. Caitlin Quinn. At the time of this recording, the third round of the Delphi is about to close, and we hope to share some of the initial results from this Delphi at the workshop. These are the steps toward the composite measures as defined by OMERACT. Step 1 is to choose the relevant domains. Step 2 is to select high-quality instruments. Step 3 is to decide on a scoring system approach, weighing or not. And step 4 is validation, putting it through filter 2.1. We believe that our existing OMERACT core set from 2010 results from the SLR and Delphi exercise represent the two first steps. I will now focus on the two latter steps in the development of composite from the OMERACT perspective that focuses on how to combine individual components and the validation. Our project has 5 steps that correspond to the last two steps towards composite according to OMERACT. In these steps, we will rely on an expert panel investigator and patient research partners. We will rely on the same individual throughout this process. At some of the steps, we will use 1000 Minds, a decision-making software to facilitate decision-making involving multiple criteria. The steps are 1. Quantifying response using clinical vignettes. 2. Virtual conference among the expert panel where the criteria will be drafted. 3. Discrete choice experiments to obtain weight. 4. Internal validation. And 5. External validation. Step 1 will be an online exercise that involves quantification of treatment responses that vasculitis expert will do independently. The choice of the outcome measures presented will be guided by the SLR and the Delphi exercise, and the range of the responses will be typical for real-life data obtained from RCTs. A clinical vignette could be something like what is shown on the screen. Mr. Jones is a 65-year-old man with a new diagnosis of ANCA-Associated vasculitis, with manifestations including rhinitis, sinusitis, pulmonary nodules, glomerulonephritis with active urine sediment but preserved renal function. He has arthralgias and constitutional symptoms. He receives treatment, and 3 months later he has no clear signs of active disease, but feels he has not achieved his previous good health status. Before treatment, his BIVA score is 6, patient global is 8 out of 10, the erythrocyte sedimentation dried 35, and pain 6 out of 10. After treatment, his BIVA score is 0, patient global is down to 2 over 10, set rate is down to 15, but pain remains at 6 over 10. Then the experts are asked to quantify this treatment response as none, minimal, moderate, major, or full. This method will highlight the areas of disagreement and consensus among experts in ANCA vasculitis. Step 2 will be a virtual conference where same experts that quantified the response in step 1 will convene, and data from the first step will be presented and discussed. Reasons for why assessment of experts differ will be explored, and 2 major goals will be achieved, hopefully. 1, consensus quantification of experts. Experts will work together to quantify the response in each of the clinical vignettes. And 2, draft criteria 6 to 12 will be drafted for further evaluation in step 3. 3. Discrete choice experiment. The discrete choice experiment will be an online study using the 1000-mind software. Same participants will again take part in the study. They will be presented with 2 criteria at a time and asked to assess which of them represent greater treatment response. After such pairwise comparison on all the candidate criteria, we will get numerical estimates for the relative importance of each criterion towards the overall response. From the numerical estimate, we will create point system in the final criteria. Thus, this step will deliver a weight for each of the criteria. For example, results of the hypothetical sample on the last slide of achieving BIVAs would give 4 points, getting CRP below 20 would give 2 points, and 50% reduction in the patient global would give 1 point. Becoming ANCA negative would give 0 point and therefore be omitted from the criteria. The 4th step is internal validation that will be used using the same clinical vignettes. But this time, quantification of the response will be done using the new criteria rather than basing it on expert opinion. Agreement between consensus response quantification for the experts in step 2 at the expert panel meeting and according to the new criteria will be calculated. External validation is the 5th and the final step, and will involve using trial data to see how the criteria difference between an arm in an RCT. And the figure shows a true two groups, A and B, that are followed over time in a setting of a clinical trial. It is challenging to obtain common support for a new measure. We have tried to have the process of towards the response criteria transparent and introduce this protest at vasculitis investigator meetings. We have sought involvement from multiple stakeholders, and we will ensure diversity in our expert panel. But the ultimate test is the performance of the final criteria in the validation phase. At that point, if we feel that these criteria advance conductance of RCTs for AAV, we will seek endorsement from OMERAT, ACR, and EULAR. With this, I conclude my presentation. I thank you for watching and hope you will participate in our workshop on December 7th. Thank you.